start with these slides. If you look at that, that's maternal mortality ratio for South Africa. Starting in 1993, it was around 77 out of 100,000 mothers giving birth died. But instead of decreasing, it increased. By 2015, 138 people giving birth out of every 100,000 died. The worst part of it to me is if we look at some of our neighbors, look at Zambia. It's a country that's far less resourced than South Africa. Look what has happened to their rate. It has decreased from 600 to still very high, but there's been a decrease. We've had an increase. Maternal mortality rate is very important because it gives you a good indicator of the overall functioning of the health system. You need to have antenatal care, primary care, you need to have hospitals, you need to have physicians, you need to have surgeons and anaesthetists. The maternal mortality rate looks bad. Our system is getting worse. South Africa is around there, $6,000, should be spending around 7% of GDP on healthcare. We're actually spending about 9%. We're spending more on healthcare than other countries with similar levels of development and similar incomes. We spend about $3,000 per person per year in the private sector, as opposed to about $600–700 per person per year in the public sector. So there's a massive inequality in healthcare expenditure. But this is, to me, the worst. Countries spending around $1,000 a year have life expectancies in the range of 70. South Africa is spending the same amount, has a life expectancy just over 56. This is 2050. So we're spending lots of money. We're spending it unequally, and we're getting very poor outcomes for what we're doing. Universal health coverage is a specific concept that relates to the understanding of three elements. The first is who is covered. If you look at South Africa, we know there are people who are not covered, who don't have access to that pool. We have different risk pools. If you're in PALMED, you belong to a different risk pool than someone else who's in PALMED or in the public sector. Public sector people have access to the national fiscus, but these are different pools. So, and then we have people like laborers, migrants, etc., who are not covered, and people, rural people. I mean, to what extent are you covered if you live in a rural village in Limpopo in comparison to someone living in Gugulethu? The second element is, do you have to make a co-payment, or is everything covered out of that pool's funds? Is that covered adequately? Thirdly, are all services covered, or is it only the PMB package? What is covered and what is not covered is the third element. So those three elements determine what universal health coverage is. So, but it can never be fully achieved. Never, because that box keeps on growing. And the other important element is it does not require a specific financing mechanism or a specific service delivery mechanism. It differs across the world. But an important principle that can never be forgotten whenever you design or work on a healthcare financing system is that you must have vertical and horizontal equity. Vertical equity means young and healthy people must cross-subsidize sick and old. And then the second critical element, if we want to achieve that, is that health systems reform is pulse dependent. We are here now. We have got a specific system. We cannot have a big bang approach that throws everything out. Today we switch off this system and tomorrow we walk into a new functioning system. The second important difficult issue is that it is redistributive. In other words, you have to take from the rich and give to the poor. This slide is from the WHO and was used at the recent Presidential Health Summit. And I think the important message which comes from Joe Cootson here is that we must take steps that move us towards healthcare. We must progress on one or two of the small difficult things. Reforms must be about solving specific problems with specific solutions. We must have identified, we've got an issue with tariffs in the private sector. How do we find a solution? We've got an issue with split risk pools in medical schemes and other environments. How do we find a solution? Health technology assessment is typically the issue. How much does it cost to give people vaccines to prevent cervical cancer? How many cancers do we prevent, and how much money would we save to it? And so you look at the cost and the benefit. And it's a formal analytical process that helps you decide on what interventions do you fund and what not. That's, as background, there are many things happening, and we are going to change, and there's a lot of change going, but now how do we get this to the best? The Medical Schemes Amendment Bill addresses some new strengthenings of governance, and it's particularly to require medical schemes, principals, officers to have certain qualifications. The boards of trustees must be properly constituted to have a wide broad of capacity and skills. It introduces new comprehensive service benefits, but it doesn't define it clearly. It does not take away the prescribed minimum benefits. They are still in law in place after that legislation. So there is some work that needs to be done on this bill. It's a lot of contradictions, and it's not very clear. It needs a lot of more detailed work and technical work to be done to do that. It requires that scheme tariffs must be published. In other words, how much money a scheme pays a provider, that must be available so that it improves clarity and transparency. And then it says that in contributions must be income-based for specific mandatory benefits, and it creates 3 risk bands. In other words, you have different contributions for children, young adults, and for adults, older adults. And then there's some misconceptions. Co-payments are not established, are not abolished. Brokers are not abolished. PMBs are not revoked, but there are now 3 sets of minimum benefits considered in the bill. These income-related contributions rely for mandatory minimum benefits only, and lay joiner penalties are not cancelled. In terms of the NHI bill, it establishes a national health insurance fund which will purchase services for the entire population. It creates a purchaser-provider split, which is a very important concept in the delivery of public services, that one part purchases from the other part. And it establishes a contracting unit for primary care, but unfortunately that's also very unclear. Is this an entity of the province? Is it another public entity? Is it part of the fund? It's not clear in the legislation. It's very confusing. And then finally, the application of the Act does not change the funding and functions of organ of state in respect of health service until there are certain other changes. So it creates a framework, but even if it were implemented today, it's not going to start purchasing services immediately from Free State provincial hospitals. So I think the governance arrangements, as it is presented in the bill, needs to be given specific attention. And also, we need to look specifically at the composition of these committees. And that is where we get to the HMI recommendations. First of all, what's very important, the market inquiry says its recommendations must be considered as a package of recommendations, because if you pick and choose from what you accept and what you don't accept in these recommendations, it could have dire consequences for some people. First, it says we must have a supply-side regulator for healthcare. Healthcare brokers in the scheme environment are fine, they play an important role. It suggests changes to the HPC requirements that limit the association between professionals and other entities. Then scheme governance is very similar to the Medical Schemes Amendment Bills. It talks about arbitration and sets up a research unit for develop the best payment mechanisms, the best payment systems, and how do we standardize coding. And then another entity that is suggested to be developed is the Outcomes Measurement and Reporting Organization. Entities like these are typically best set up by practicing physicians, and that work must be pretty well advanced for about 5 or 6 years before we can actually start making it a statutory requirement. Okay, now I want to talk about what they say about risk adjustment in relation to the equity which we're speaking about. If you look at our South African situation, this is a World Bank report, which shows the black line at the bottom tells you where are the people with earning. The people are arranged from the lowest income on the left to the highest income on the right. And on the vertical axis, you see how much in relation to the black round, how much people's income are being earned. Lower income people earn a small proportion of the country's total income, and the last two deciles, 9 and 10, earn the most. Now, a system can deal with inequality in two ways. The first is by taxing the people more who earn there, and secondly is by having your social spending correctly. It's above the line, it's above the 45-degree line, but only slightly. And the reason for that is simply, as a country, including public, private sectors, all of us, we're spending too much money on tertiary care. Tertiary care is accessible to your higher groups of your higher deciles. Primary care serves the lower deciles. So to be redistributive, one needs to focus more on primary care. So if we evaluate, we look at this World Bank study that looks at both sides. It looks at the taxation side and it looks at the expenditure side. It actually, South Africa is one of the world leaders in terms of, through its fiscal system, it actually benefits, reduces inequality. We do that better than people in Brazil, Costa Rica, Uruguay, Mexico, Bolivia, Armenia, and all of these do. And this is to show you, when we spoke about the REF, which was the old suggestion, which was due to be implemented around 2008, we said a member and employer will make a community contribution-related contribution to a medical scheme, and then that money will flow from low-risk schemes to high-risk schemes through a risk adjustment fund so that you can get that horizontal equity. So even if you're in one scheme, a young and healthy person in another scheme would fund you. Market inquiry report now suggests, they say, no, that's not good enough, because what that would do is if you're young and healthy and low income and you belong to a low-cost medical scheme, you now have to cross-subsidize some other old and sick people in the old system. So what they're suggesting is through a contribution subsidy that is linked for a risk income adjustments fund, so that money flows only one direction, so that high-risk schemes will get some money, low-risk schemes won't. There are gross imbalances in funding between the different provinces, and that can be done through what is called a central equity fund, so that you could eventually reach a point where, regardless of where you're living in Limpopo, when you're rich or you're poor, you could actually get the necessary flows of necessary cross-subsidization set up. This is a population, percentage of the population belonging to medical schemes. If a household earns more than 500,000 a year, around 70 to 80% of people belong to medical schemes. So that is the thing, that income. But if you look at how few people actually earn that, 90% are there, less than 50,000. Half of the population earns less than 4,200 Rand a month. That is what we're up to. We've got to know that, and we've got to design a system that caters for that, and it caters for the rich. The great part of the Health Summit said this: we must own the problems, and we must take responsibility to find those collective solutions, and I found this very, very strong. It's a whole vibe that we got there. UHC is not negotiable. We've got to get universal health coverage. NHI is a means to that, eh? But where do we as a country, involving all stakeholders, go? And then the presidency will have oversight and stewardship leading the implementation, because there are many departments. It's not just the Department of Health. To me, what I got from there is all participants acknowledge that the present system has many failing elements. There was immense positive energy displayed across the board. People are angry about the parts of the system that's not working. People are unhappy, but they spoke freely about their concerns and the system and the current plans. And the next few weeks is critical in developing that compact, which will be signed on 10th December, so that we can develop implementable plans that can be done quickly to strengthen the health system and take steps towards universal coverage. Thank you very much, Jim.